Hi everyone. Today we'll be continuing our discussion on diabetes medications, in particular sodium glucose cotransporter 2 inhibitors. SGLT2 inhibitors, commonly referred to as flozins, are a relatively recent class of glucose-lowering medications. Common SGLT2 inhibitors that you'll encounter in clinical practice include empagliflozin, canagliflozin, and dapagliflozin. These agents lower blood glucose by promoting renal glucose loss through inhibition of SGLT2-mediated glucose reabsorption in the proximal renal tubules, which is responsible for reabsorbing approximately 90% of filtered glucose. This urinary glucose loss represents a loss of calories, which contributes to weight reduction. The extent of glucosuria is proportional to circulating glucose levels. As plasma glucose decreases, less glucose is filtered and excreted, resulting in a diminishing drug effect, which is actually beneficial because when blood glucose levels are within the normal range, the risk of hypoglycemia with these medications remains low. The glucose-lowering efficacy of SGLT2 inhibitors is reduced in the presence of impaired renal function. And finally, most agents in this class selectively inhibit SGLT2. Now, SGLT2 inhibitors may be prescribed either alone or in combination with other glucose-lowering agents. In addition to improving glycemic control, SGLT2 inhibitors are associated with weight reduction and modest reductions in blood pressure, making them particularly appropriate for individuals with obesity and hypertension. So for example, if you have a patient who is on metformin and they're not achieving adequate glycemic control, and you intend to add on a second agent, you should assess their comorbidities. If this patient is obese, hypertensive, has cardiovascular disease, or has signs of diabetic nephropathy, SGLT2 inhibitors would be a good agent. Large cardiovascular outcome trials have demonstrated that empagliflozin, canagliflozin, and dapagliflozin reduce cardiovascular events in patients with established cardiovascular disease or those at high risk. Treatment with SGLT2 inhibitors typically results in a reduction in HbA1c of approximately 7 to 13 millimoles, or 0.6 to 1.2%, alongside an average weight loss of 2 to 4 kilograms over a period of 6 to 12 months. Their glucose-lowering efficacy is greatest in individuals with preserved kidney function, and they are currently licensed for use in patients with an estimated glomerular filtration rate above 45. Studies have also shown important secondary benefits, including a reduced risk of hospitalization for heart failure and slower progression of diabetic kidney disease. The most commonly reported adverse effect is an increased frequency of fungal genitourinary infections, such as vulvovaginal candidiasis in women and balanitis in men, due to elevated glucose concentrations in the urine. The osmotic effect of glucosuria increases urine volume, which may lead to volume depletion, dehydration, and postural hypotension, particularly in hot climates or in susceptible individuals. Rarely, SGLT2 inhibitors can precipitate diabetic ketoacidosis, which may occur with only mildly elevated or normal blood glucose levels. This is what we call euglycemic diabetic ketoacidosis. So, if a patient presents to you with significant metabolic acidosis and ketonuria, however, their blood glucose is in the normal range or only mildly elevated, it is important to assess their drug history to see if they were using SGLT2 inhibitors. Canagliflozin has been linked to an increased risk of lower limb amputations and bone fractures. And finally, extremely rare cases of necrotizing fasciitis of the perineum, also known as Fournier's gangrene, have also been reported.